Everybody, good morning. Welcome to Journal Club. We'll get started. I hope everyone's having a good month so far. So again, welcome everyone to the Orlando GI Journal Club. Today is May 4th, and we will be reviewing some interesting articles published this month. Our first study was published in the Red Journal this month. It's looking at primary norfloxacin for prophylaxis in APA-SL defined acute and chronic liver failure. Bacterial infections are common in patients with acute on chronic liver failure. And incidence within 30 days is reported of up to 45% and is a strong predictor of mortality. Therefore, infection prevention is critical for the management of patients with acute on chronic liver failure. Prophylactic antibiotics are recommended for patients with cirrhosis and variceal bleeding and low acidic fluid protein for primary prevention of infections. The aim of this study was to determine if intestinal decontamination with norfloxacin might improve outcomes in patients with acute on chronic liver failure. And they looked at the Asia-Pacific Liver Association definitions of acute on chronic liver failure. The study is based in Hyderabad, India. It is a randomized trial, double-blinded, placebo-controlled, and it's looking at, it was conducted over an 18-month period from October 2019 to May 2021. They included all patients with acute on chronic liver failure aged 18 to 75 years. Patients were randomized to norfloxacin, 400 milligrams taken daily for 30 days, and compare that to placebo taken daily for 30 days. Standard medical therapy administration was permissible in both groups and included administration of diuretics, steroid therapy for alcoholic hepatitis and autoimmune hepatitis, use of antivirals for hepatitis B and C, beta blockers, lactulose for hepatic encephalopathy, and nutritional support. The primary outcome was to look at the incidence of bacterial infection at days 30 and 90. So looking at the baseline characteristics, there was 72 patients enrolled in the norfloxacin group and 71 patients in the placebo group. The mean age was around 43 years. The majority of patients were men. Mean BMI was about 24. When looking at the etiology of the acute event, the majority of cases involved alcohol. The chronic etiology for their chronic liver failure, also in the majority of cases involved alcohol. Steroid therapy was used in 32% in the norfloxacin group and 25% in the placebo group. If you look at the MELD scores, the mean MELD score was 28 in the norfloxacin group and 27 in the placebo group. Now, when they looked at incidence of bacterial infection over the period of 90 days of follow-up, they found that the difference, there was a significant difference in the incidence of bacterial infection, with significantly higher rate of bacterial infection is in the placebo group compared to the norfloxacin group, which is the blue line here. Placebo is the red line. And as you can see at 30 days, the p-value of the difference in the infection rates is 0.03, and at 90 days was 0.02. When they looked at the types of infection encountered in these patients, they found no difference in the types of infection. As you can see, UTI was seen most commonly, 23%, followed by SBP and then pneumonia. And then looked at transplant-free survival over the 90-day period. And as you can see, the transplant-free survival was not significantly different between the two groups. As you can see, the red line here is placebo, and the blue line here is norfloxacin. And if you look at the p-values, it's 0.084 at day 30 and 0.058 at day 90. The adverse events were compared also between the two groups. When looking at drug-related side effects or events attributed to kind of possible drug-related events. There was no difference between the two groups, p-value of 1. However, they did find that the rate of hepatic encephalopathy was significantly higher at 52% in the placebo group compared to 32% in the norfloxacin group with a p-value of 0.01. They found no difference in the rates of acute kidney injury between the two groups, although there was a trend towards a significantly higher rates of acute kidney injury in the placebo group at 36% and only 23% in norfloxacin, although this difference was not statistically significant. The main limitation of the study is that only patients with acute on chronic liver failure was included in the study, with exclusion of patients with hepatic encephalopathy to avoid confounding effects of rifaximin. The definition of acute on chronic liver failure was also based on the Asian Pacific Association for the Study of Liver criteria only, as the study is based in India. So the main take-home point is that norfloxacin as primary prophylaxis was able to effectively prevent bacterial infections in patients with acute on chronic liver failure when compared with placebo. Now, our next study is by Denise et al. It is looking at treat-to-target strategy versus standard of care for patients with moderately severe to severe Crohn's disease treated with ustekinumab. Please forgive my pronunciation. It has a lot of syllables. This is a Stardust trial. It's a randomized phase 3b trial, open label multicenter. Ustekinumab is a fully human immunoglobulin G1 kappa monoclonal antibody antagonist to human interleukin-12/23p14. It neutralizes interleukin-12 and interleukin-23 mediated cellular responses. The treat-to-target strategy basically means that you define treatment targets and facilitate decision-making in clinical practice based on whether those strict targets are met. So you can base your target on endoscopic lesions, although more commonly investigators are choosing inflammatory markers such as CRP or fecal count protectin, which are easier to measure than performing frequent endoscopy in our patients. So the aim of the study is to assess whether treat-to-target strategy with early endoscopy, regular biomarker and clinical symptom monitoring, and dose intensification in response to these responses for persistent inflammatory activity was more successful in achieving endoscopic improvement than standard of care, clinically driven maintenance strategy in patients with moderately severe active Crohn's disease. In patients with moderately severe or severe active Crohn's disease receiving ustekinumab. So again, this is an open label randomized trial, phase 3b study. This was conducted in Europe in 12 countries. They took patients with moderately severe to severely active ileocolonic or ileocolonic Crohn's disease. And they defined patients with CDAI of score of 220 to 450 with an endoscopic activity, a simple endoscopy score of CD of at least Crohn's disease for at least 3. They looked at they allowed stable doses of immunosuppressants, mesalamine, antibiotics, and oral corticosteroids, and all patients initially received weight-based infusion of ustekinumab at dose of 6 milligram per kilogram at baseline, and then subcutaneous ustekinumab at 90 milligram dose at week 8, and then at week 16, and patients with the CDAI improvement of at least 70 points were then randomized to standard of care or treat-to-target strategies. For standard of care, they dosed every 12 weeks in patients with adequate response to induction, or every 8 weeks in whom there was lots of response when given the every 12-week dosing, and treat-to-target was when patient was when an endoscopy was performed at 16 weeks to then determine the frequency of administration of the subcutaneous dosing of ustekinumab. The entire follow-up period was 48 weeks. The primary outcome was to look at endoscopic response at the end of 48-week follow-up. So as you can see, 219 patients were randomized to treat to target, and 221 patients were randomized to standard of care strategy. And as you can see, the majority of our patients were female in treat to target, 52%, although evenly split in the standard of care group. The mean BMI was 23 in both groups. The symptom duration was 7.7 years in treat to target versus 5.9 in standard of care group. The CDAI scores were very similar, 273.5 versus 273, the standard of care. The CRP at baseline was 7.6 in treat to target and 7 in standard of care group. When looking at the disease location, the majority of patients in the treat to target group had ileocolonic disease, 39%, followed by colonic, and then ileo was a little different composition in standard of care group, 40% in colonic, followed by ileocolonic, and then ileo. There was not significant baseline, but there was higher rate of complicated Crohn's disease phenotype in the standard of care group at 23%, versus 16% in treat to target. Now, the authors first looked at the endoscopic response at week 48. And as you can see, there was no difference in treat to target group versus standard of care group, which is in red here, with p-value of 0.87. So as you can see, these authors conducted two comparisons. One was non-responder imputation, and then a second analysis was last observation carried forward. In the non-responder imputation, patients with missing data at the end of follow-up, so at week 48, were considered to have achieved their endpoint. But in the last two follow-up analysis, patients who had missing data at 48 weeks were allocated the outcome that they achieved at their last point of follow-up. When looking at endoscopic remission and mucosal healing, they found that there was no significant difference between standard of care and treat to target groups. And as you can see, the rates were pretty similar regardless of the type of statistical analysis that they decided to do, with p-value ranging from 0.3 to 0.45. They then also looked at clinical outcomes and biomarkers at 48 weeks. As you can see, there was a significant difference in the CDAI 70 response, with a slightly lower response seen in the treat to target group compared to the standard of care group, with p-value of 0.042. But when they looked at other clinical outcomes and biomarkers such as corticosteroid-free clinical remission, corticosteroid-free clinical remission among those receiving corticosteroids at baseline, corticosteroid-free clinical remission among patients in clinical remission, and complete biomarker response, they found no difference between the two groups. When looking at the adverse events, the overall rate of any adverse event was 86% in treat to target versus 81% in the standard of care strategy. The most common adverse events range from nasopharyngitis to exacerbation of Crohn's disease, headaches, fever, joint pain, abdominal pain, etc. When looking at infections and infestations, the rates were actually quite high for both groups, 46% in treat to target and 43% in standard of care group. 5% of patients in the treat to target group encountered adverse events that were severe enough to lead to discontinuation of their treatment, and this was seen in 9% of patients in the standard of care group. The main limitation of this study is the lack of blinding because it was an open label study, and only CDAI responders after the initial dose of ustekinumab were randomized, which may partly explain the high week 48 response rates in this study. So take a point from this study is that timely escalation of ustekinumab therapy for patients with Crohn's disease based on early endoscopic response, clinical symptoms, and biomarkers did not result in significantly better endoscopic outcomes at week 48 when compared to just symptom-driven decisions alone. Our next randomized trial is using non-viable probiotic in IBS. The study is important because IBS is seen very commonly in GI practice, and IBS has been associated with changes in the GI microbiota, although clear etiology is still not known, and increased incidences are observed after acute GI infections or use of antibiotics. Therefore, therapeutic agents targeting GI microbiota, such as probiotics, hold potential treatment for IBS. However, evidence for the efficacy of probiotics in IBS has been inconclusive. Now, the non-viable bacterial lysate, or BL, of cells and cell fractions of E. coli and Enterococcus faecalis has been approved in Germany and Switzerland, has been available since 1954, and has been indicated for IBS. The aim of this investigation was to see the effectiveness of treatment with a lysate of E. coli and E. faecalis cells in IBS on frequency and severity of IBS symptoms. So this was a randomized trial, phase 4, double-blind, placebo-controlled study. It was conducted in Germany across 30 centers where this BL is approved for use. Patients were randomized to either BL, the lysate of E. coli and E. faecalis, or placebo. And treatment period was 26 weeks. As you can see, the majority of our patients enrolled in the study were female. 187 patients were enrolled in the BL group and 197 in the placebo group. And as you can see, 70% of patients in the BL group are female versus 68% in the placebo group. The majority of the patients enrolled in the study were Caucasian, and the mean age was 47 for BL versus 45 for the placebo group. BMI was 26, and duration of IBS symptoms ranged from 124 months in the BL group to 109 months in the placebo group. When looking at the different subtypes of IBS, in the BL group, the most commonly encountered type was the IBS diarrhea group, followed by the mixed subtype, then constipation, then unspecified. Again, the pattern was similar for placebo. The most commonly encountered IBS subtype in the placebo group was IBS diarrhea, then mixed, then the constipation, then unspecified subtypes. Now they looked at the response to IBS GAI and IBS AP30 criteria, and as you can see, there was no difference between BL and placebo when looking at the IBS GAI responder and IBS AP30 responder with rate of response of 17 versus 14 for the IBS GAI with p-value of 0.479. And for the IBS AP30 responder, it was 43% versus 35% for placebo with p-value of 0.142. We're looking at the sensitivity analysis for response to IBS, AP75 for IBS subtypes. As you can see, there was some difference which did light up statistically for the IBS group, for response being higher with the BL at 48% versus 30% for placebo with p-value of 0.3, although these differences were not significant for the other types of IBS subtypes. So the main limitation in the study is that IBS-C group is underrepresented in the study. Also, this lysate is really only available, looks like, in Germany and Switzerland, which limits the generalizability of the study results. And so the main take-home point from this study is that the lysate of the cells of E. coli and Enterococcus faecalis, a type of probiotic, if you like, is not effective across all the IBS subtypes. However, is showing some promise for the IBS diarrhea subtype. So our next study is optimal timing of cholecystectomy after necrotizing pancreatitis, published in Gut by Hallensleben et al. Cholecystectomy is recommended following an episode of biliary pancreatitis to prevent recurrent biliary events that include further episodes of recurrent acute pancreatitis, cholangitis, and acute cholecystitis. Same admission cholecystectomy has been shown to be safe in patients with mild biliary pancreatitis when performed within the same admission to reduce recurrent biliary events, but optimal timing for cholecystectomy in patients with acute necrotizing pancreatitis is not clearly known. And so the aim of this study was to look at the optimal timing of cholecystectomy in patients with necrotizing biliary pancreatitis. And the definition of optimal timing was the point at which there was a lowest risk of recurrent biliary events and the lowest risk of complications from cholecystectomy. So this was a post hoc analysis of data that these authors had included as part of prior randomized trials and patients who were screened for inclusion in the randomized trial performed previously. And they included patients with moderately severe or severe acute biliary pancreatitis with peripancreatic collections and CT severity index of at least 3. And as you can see, the study cohort ended up being 248 patients after excluding patients with only mild pancreatitis, after excluding patients who had cholecystectomy previously, and patients who had cholecystectomy at the same time as endoscopic treatment. And as you can see, out of the 248 patients with necrotizing pancreatitis who were then candidates for cholecystectomy with biliary acute necrotizing pancreatitis from biliary etiology, 191 patients ended up receiving cholecystectomy. And then they divided up the timing of the cholecystectomy in 2-week increments. So less than 4 weeks after discharge, then 6 weeks, 8 weeks, 10 weeks, and 12 weeks. So when they included the 248 patients, these were the baseline characteristics. So the mean age was 60 years, 47% of the patients were female, BMI was 27. As you can see, the majority of the patients included in the study, despite the acute necrotizing pancreatitis, were ASA grade, only 1 or 2, with only 7% being grade ASA grade 3. The 99% of patients, for 99% of patients, this was their first indexed episode of acute pancreatitis. The mean CT severity index was 6. And when looking at the degree of parenchymal necrosis, 15% had more than 50% necrosis, and 48% of patients had extrapancreatic necrosis only. 35% of patients were managed in the ICU at some point during their admission, and 26% had concomitant organ failure. The mean length of stay was 23 days and the total follow-up was 76 months. Now, this is looking at the risk of biliary events according to the timing of the cholecystectomy. So as you can see, the row above here is comparing the risk of biliary events when cholecystectomy was performed at less than 4 weeks or more than 4 weeks, and then 6 weeks, 8 weeks, 10 weeks, 12 weeks. So if you look at the overall biliary events, the difference in risk of the rate of biliary event only really lights up when you get to week 10. So if you have cholecystectomy performed less than 10 weeks after discharge, the rate of biliary event is 14, but in patients who had it performed at more than 10 weeks, the rate of biliary events was 28%, and this difference was statistically significant with p-value of 0.02. Now, the only other place really where this p-value lights up between two groups is at the 8-week mark post-discharge when the cholecystectomy is performed. If you look at recurrent pancreatitis, it's 2% when cholecystectomy is performed at less than 8 weeks versus 11 when performed more than 8 weeks post-discharge with p-value of 0.02. Now, when looking at the risk of surgical complications according to the timing of cholecystectomy, interestingly, there was really no statistically significant difference in the rate of complication with increasing time from time of discharge. But one thing to note is that for patients that appear to have had infected necrosis following cholecystectomy, and also when looking at the adverse events during cholecystectomy, again, there was no difference, as was the case for the overall adverse events. So for patients develop infected necrosis after cholecystectomy, and risk of complications from cholecystectomy did not decrease over time. Then when looking at the risk of recurrent biliary events prior to cholecystectomy in patients who had undergone an ERCP, they found that there was no significant difference between the rates of recurrent biliary events in patients who did or did not have an endoscopic sphincterotomy. The main limitation of the study is that this is a post hoc analysis of data of patients who were included in prior randomized trials. The timing of cholecystectomy was determined by the treating clinician and may have been influenced by logistic constraints like surgery waiting time, rather than being solely dependent on clinical need, and low rate of infected necrosis post-cholecystectomy for patients in total did not allow comparison with effect of early versus late cholecystectomy on infection rates in patients with necrotic collections. So the take-home point is that the risk of biliary events increases when cholecystectomy is postponed, with the turning point at 8 weeks after discharge. However, delaying cholecystectomy did not reduce the risk of peri-procedural complications. Therefore, optimal timing of cholecystectomy after necrotizing biliary pancreatitis in the absence of peripancreatic collections appears to be within 8 weeks after discharge. So for a quick recap, primary norfloxacin prophylaxis was able to effectively prevent bacterial infections in patients with acute and chronic liver failure. Timely escalation of ustekinumab therapy for patients with Crohn's disease, which was based on early endoscopic response, clinical symptoms, and biomarkers, did not result in significantly better endoscopic outcomes at week 48 than symptom-driven decisions alone. The bacterial lysate type of probiotic is not effective across all IBS subtypes, however, may be effective in IBS diarrhea subtype. Risk of biliary events increases when cholecystectomy is postponed, with a turning point at 8 weeks after discharge, but delaying cholecystectomy did not reduce the risk of peri-procedural complications, and therefore optimal timing of cholecystectomy after necrotizing biliary pancreatitis in the absence of peripancreatic collections is within 8 weeks after discharge. Thank you so much for joining us today. The next journal club is on June 1, which is the first Wednesday of June. Thank you so much for joining us again today.